All right, good afternoon, everyone, and welcome to today's webinar, Legal Repercussions of Public Health Emergency Rescissions, brought to you by the Network for Public Health Law and the American Society of Law, Medicine, and Ethics. I'm Daniel Wacker, the Program Development Associate at the Network for Public Health Law's National Office, and I'll be your host for today's webinar. We strongly encourage attendee participation, so feel free to submit questions during this time through the webinar chat or through the Q&A function at the bottom of your screen. All you need to do is click that button, and then all the panelists will have those questions and can answer them throughout the webinar. Your moderator for today's webinar will be Summer Gaith, a senior legal researcher at the Network for Public Health Law's Western Region Office. So Summer will be leading us through the rest of today's presentation, so I'll hand it off to her.
Hi, everyone. I'm pleased to introduce you all to our wonderful and expert panelists, Professor Lawrence Gostin, Lauren Didon, and Erica White. I'll briefly introduce the panelists to you all, and Professor Lawrence Gostin is the founding O'Neill Chair in Global Health Law, Faculty Director at the O'Neill Institute, and Director of the WHO Collaborating Center on Global Health Law. Lauren Didon is a Senior Legal Policy Advisor at the National Governors Association, and Erica White is a Senior Attorney at the Network for Public Health Law, Western Region Office. Today, our experts will discuss how the PHE has completely changed the public health legal landscape over the past 3 years and what to expect when the emergency officially ends. After a presentation from the panelists, we'll take all questions and comments, so please put them in the chat box or in the Q&A. And without further ado, I'll turn this over to Lauren Didon to begin the discussion.
Great. Thanks so much, Summer. It's such a pleasure to be here with such an esteemed panel of speakers too. I'll go ahead and share my screen. I don't know if someone else needs to stop sharing before I do that. Okay. Let me get that up there. Can you see it? Okay. Okay, excellent. Well, again, thanks so much for inviting me to speak here today. The first thing I want to do is just ask folks to take a step back in time with me back to, March and February of 2020. I know we probably have a varied audience here today on the call, but I'm sure there's some government officials on the line here. So I want you to take a step back in time with me to March and February of 2020. Maybe it was your colleagues or friends, maybe it was someone in your state or territory, but someone was having a discussion with your governor about how you're going to respond to this new pandemic and when, if, and how you are going to declare an emergency. My team and I are on the other end of the spectrum in this flashback, sitting in our offices, tracking every state and territory's emergency declaration with Erica and her team, really just watching history unfold as every declaration trickled in. So there's been a lot that's changed since then and a lot that's been learned. So we're really looking forward to diving into some of those legal and legislative changes during this session and reflecting on this new state and federal landscape for future emergencies too. So just want to cover a few things in the next few minutes. First, just briefly share a little bit about NGA. Second, provide kind of a broad overview of gubernatorial emergency powers. Then talk a little bit about the state COVID landscape, both litigation and legislation, some of those challenges and changes we saw. And then fourth, just conclude with some lessons learned we've heard from Governor's legal counsel on these issues and how we can learn in future emergency events too. So I won't spend too much time about NGA. We're the bipartisan membership organization of our 55 governors of the states and territories. You can see we're kind of categorized into 4 different parts. And I specifically work within the Center for Best Practices, which has a different program areas across different state policy issue areas. And I specifically support a network of governors legal counsel, which you can imagine became very active on the onset of the pandemic. In March 2020, we started holding weekly calls with the network of legal counsel featuring experts like Professor Gostin and others, just to provide a forum for counsel in different states to talk with each other, what they were seeing, what problems they were confronting, and what they were planning to do to overcome some of these challenges. And so one of the big fundamental questions that came up was related to gubernatorial emergency powers, So I just wanted to take a few minutes here to just kind of level set, talk a little bit about these powers and how they were used during the pandemic. So as we know, emergency powers are the authority granted to the governor or other executive during an emergency or crisis. So they allow the governor to take swift and decisive action to protect public health, safety, and welfare, and coordinate the state's response. Really from day one, as we all know, governors must be prepared to respond to day-to-day emergency events like tornadoes, floods, hazardous material spills, but also catastrophes on the scale of COVID and Hurricane Katrina or even September 11th. So because of this and because of the magnitude an event like this can have on a state, it's really crucial that governors and their staff understand the scope and extent of these powers and really the logistics of how to declare an actual emergency. So just taking a look at some of those components here, just briefly, they're generally activated, these powers, through an implementation of a state declaration or proclamation of emergency or disaster. And as we said, they enhance governors' capabilities, coordination, and collaboration across different levels of government and really bolster that response effort. So although statutory schemes vary, all governors are given some sort of power to declare one or more types of emergency, whether that's a disaster emergency, a state of emergency, a civil preparedness emergency, or specifically a public health emergency. It really just depends on that state. And states specify how these legal declarations are made, if there are durational limits or renewal limits, and whether the legislature needs to be involved or other potential constraints. And while they're, unique to each state and unique to each event, really, emergency declarations generally address a few things within the order itself: effective dates, geographic areas of the state covered, conditions giving rise to the emergency, applicable response actions, of course, and the agency leading the response. You can see some thoughts about scope of orders, but I'll get to those in a minute when we're actually talking about the COVID pandemic specifically. So kind of taking a step back in time. So the COVID-19 response marked the first time in US history when all 55 governors of the states and territories issued some type of emergency declaration in response to the same incident. So you can see on the slide some actions that occurred in the first 3 months of the pandemic. I won't talk about the federal side because I know we'll have additional speakers talking about that. And please note that local actions aren't included on this slide because the slide's just not big enough. But really just to look at the state side, some of those key actions in those first 3 months. Governors began declaring on January 29th, starting with some of the territories and West Coast states. And by March 16th, every state and territory had declared some type of emergency. And today we still have around 9 states and territories or so still with active emergencies in place. These orders have certainly evolved and have been adapted throughout the pandemic period, and many are set to wrap up in line with the expiration of the federal emergency on May 11th of next week. So, as we know, these emergency powers were used as the legal basis for many COVID-19 response efforts. Some of those actions you can see on this slide here. This is certainly not an exhaustive list, but really just to kind of look at some of those actions that were taken and try to categorize them in a few different buckets. So, of course, on the operational front, with altering contracts and procurement procedures, suspending and waiving rules and regs, activating response plans, unlocking funding or resource allocation. Of course, the big bucket of public health mitigation measures, so isolation and quarantine, travel restrictions, stay-at-home orders, essential business designations, gathering limits, masks, everything there, reporting, surveillance. And then other response actions, of course, too: eviction moratoriums, licensing, telehealth, correctional population changes, liability protections and immunities, a lot of these actions taken. And even though we've seen similar actions like this in other disaster efforts, like we said, hurricanes, fires, even public health events like the opioid epidemic, the longer term and deadlier nature of COVID, of course, necessitated a longer emergency period than we typically see in these shorter term disaster response efforts. So with these unprecedented events, of course, came an unprecedented flurry of legal and legislative changes to such authorities. So just to dive into some of those legal litigation and legislation that we saw, particularly impacting governors and state level policies. So as we said, emergency powers are intended to enable swift and effective action in response to an emergency, but they're of course subject to legal and constitutional limitations to ensure that they're used appropriately and do not infringe on individual rights or liberties. So almost immediately as emergencies were declared and executive actions were taken, there was legislation and litigation. So we tried to track specifically the litigation piece. We got lots of questions early on in the pandemic about, who's being sued for what, trying to just manage this influx of litigation. We tracked at least 400 and 450 lawsuits that were brought in over 50 states and territories, challenging executive actions taken by governors or state officials in COVID. So we'll talk about that in a moment. And on the legislative front, over 1,000 bills introduced in almost all states that impact and specifically limit state executive authority to respond to the pandemic or a future public health event. So we'll talk about both those just for a couple minutes. Looking at those key legal issues. So, of course, there's been hundreds, thousands of lawsuits related to COVID filed in the past couple of years, but our data set here is just lawsuits involving the governor and potentially a state agency. And really our key tracking took place within the first 18 months or 2 years of the pandemic. So that's kind of our data set, governor involved litigation in those first couple of years. So we saw challenges kind of generally fall into 4 categories. First one being scope of emergency and executive authority. Second, social distancing or mitigation measures. Third, mask mandate prohibitions, and 4, vaccine mandate prohibitions. And of course, there's overlap here. They're not mutually exclusive, but that's just kind of a way that we've categorized those major challenges. You can see that the key claims that we saw on the right side, First Amendment, freedom of religion, speech, Second Amendment related to gun store closures, Fifth Amendment, takings, 14th, substantive and procedural due process, equal protection, interstate travel, and other constitutional claims. And again, these challenges were really looking at all those different boxes from the previous slide, stay-at-home orders, essential business designations, limits on public gatherings, specifically related to church gatherings or public worship places, mask and vaccines. And then we also saw, a lot of elections and correctional litigation as well. And generally, we found that most state and federal courts did affirm governor's emergency authorities, particularly in those first 18 months of the pandemic. But we did have courts outline specific limitations on powers within COVID too, particularly in cases involving religious liberty or scope of authority, and especially as the pandemic endured and emergency declarations and restrictions continued to be in place. There were also a few key state Supreme Court cases, some involving state legislators or legislatures. If you're one of those states, you probably know that, those state Supreme Courts weighed in on governor's authority to declare or extend emergencies in particular, some spending authority litigation too. Most courts upholding such powers for governors, but others going so far as striking down the emergency declaration itself. So really just saw some variation there. And about on the Supreme Court side too, about a dozen or so COVID cases involving governors reaching the Supreme Court through the emergency docket, generally dealing with vaccine mandates, religious freedom challenges, state elections, because of course it was an election year, 2020. And in those emergency appeals, the court generally upheld those state actions too and refrained from intervening. But of course, we did see the court block certain actions involving governors restricting religious gatherings. So just wanted to make note of that. Taking a look at some of those legislative changes, NGA and our partners at CDC and ASTO, the State Health Association, recently published an article in the Journal of Emergency Management that highlights some of the new legislative landscape for future response capabilities. The article was mostly informed by ASTO's legislative tracking of these issues over the past couple of years, so highly encourage you to visit their surveillance tracking tool on Law Atlas. The link is there if you want a state-by-state breakdown or an issue-by-issue breakdown of legislation. But all to say, the article discusses both enhancements and restrictions of these powers, which we'll talk about here just for a moment. As we said, hundreds of bills introduced in 2020, 2021, 2022 that impact government emergency response capabilities, some to enhance, but mostly to restrict these authorities. And despite legislation being introduced in almost every state, only about 20 or so states actually pass legislation. And we're sort of seeing how that's actually being implemented and how that's playing out now. So on the enhancement side, real quick, increasing vaccine access and expanding scope of practice for administering vaccines, strengthening public health investigative authority, preclusion of local orders, but mostly we saw restrictions or efforts to restrain those authorities, mostly related to oversight of executive authorities. So whether that was implementing or enacting some sort of legislative oversight committee, notice requirements for before executive actions are taken, limits on the duration of the emergency or how many times it can be renewed. So whether that's a number of days or a cap on renewals before you're involved in the legislature. And limits on the actual scope of powers themselves. So whether that's requiring a justification to be within the orders for certain actions or categorical limitations. So, you can't pass something involving private businesses or religious facilities or sporting events or schools. So really restrictions both on kind of the procedural side and the substantive side too. And again, as we said, despite the introduction of hundreds of these bills, only a small percentage pass, and we're seeing how these are kind of being implemented now. I believe in 2023 sessions, we've seen a decrease in this type of legislation, and even some states going back and looking at what they passed the past couple of years and saying, do we need to amend that? Do we need to make the declaration period a little bit longer? So interesting kind of trends there. But all to say, the legal and legislative landscape does look a little bit different in many states, so we definitely need to be aware of that in future emergency events. So just to close out here with some lessons learned and looking forward, there's certainly no batch of government officials or legal counsel that are better versed in emergency preparedness than the ones that served during the pandemic. So we wanted to capture this knowledge. So we surveyed our network of governors council a few months ago, just for their anonymous and candid reflections on what it was like to serve their governor during this type of event. So responses kind of fell within these 5 different buckets. The first one was understanding your tools. So what can your governor do under these emergency statutes? How did the public health nature of this emergency fit within those existing frameworks? Not all powers are the same across the states, of course, so you can't always compare your actions to your neighbors and even within your state. Your governor's powers are different than your state health officials. So knowing those gaps and overlaps is really critical. The second bucket just dealt with, the need to act quickly. And there's not a lot of time to think when you're dealing with an all-consuming nature of an emergency like this. You're going to have to make real-time decisions, which can be stressful when you're an attorney and you're thinking about those legal ramifications. So developing processes especially when you're issuing all those executive orders for drafting, vetting, approving, including a rational basis and dates within the orders, because that's immediately what the court will look to, documenting your justification for the actions, and really knowing what your exit strategy is. So if you're implementing an action, what's it going to take to lift that action? What's it going to take? And just given the influx of litigation in states, trying to develop strategies early to defend those legal challenges was really what we heard was important as well. The third bucket, just the all hands on deck nature of the event. So organizing a response team, elevating a strong senior team leader to run the response, someone who can take inputs from public health, but balance those with other stakeholders and make decisions and recommendations that align and reflect the governor's overall strategy and really risk tolerance too. Everyone in state government and local governments, has a role in the emergency, whether their agency touches the pandemic on its face or not, and people are going to want to sit at that table. So that coordination piece is really important. And on the legal front, coordination, centralizing your legal work so advice is consistent, whether that's in the governor's office or across your state agencies too. And the need, of course, to work with your state attorney general, because they very well might be the ones defending you in court. The fourth bucket here, and then I'll wrap up with a couple more remarks, is just about communications. The pandemic was a communications event. The governor's the leader of the state during an emergency, and certainly looked to as such in that event. They need to be trusted. They're really an important and effective communicator. A lot of governors held daily press conferences to share what they knew and what they didn't know, really emphasizing transparency. And, just the need to communicate with different stakeholders, whether that's the public or state government or constitutional officials, tribal partners, federal government, of course, and knowing that messaging can be, more important than enforcement, because buy-in from public is critical to have any impact. The last bucket we saw was just in terms of balancing risks. So in an unprecedented event like this, there's going to be a lack of certainty. And if the legal basis is unclear, you really have to ask, is this action worth it? And what is our plan to justify it? So decisions need to be made in a way that protects constitutional rights, of course, but also provides for health, safety, and welfare of the public in general. So really every action having that accompanying risk assessment and balancing and vetting those actions with your coordinating team. So just to close out, when the pandemic began, most courts were looking to Jacobson v. Massachusetts, as we know. And as time went on, citations to that case kind of dwindled. And I think it's fair to say, we have a fairly robust and evolved jurisprudence related to government public health authority to draw from in future emergencies. States need to be aware of how their legislation, how their state laws change in regards to responding to emergencies. And really governors and their staff have learned a lot these past few years in terms of crafting executive orders, scope of authority, and adapting actions and response efforts accordingly. So we're hoping to eventually turn these legal lessons learned into a brief or something we can share, since we really got such great on-the-ground info from that survey, almost like an oral history. And I definitely encourage you to do a similar exercise in your offices if you haven't done so already, just to pass on to your successors. It doesn't have to be a huge endeavor, but you all hold so much knowledge and experience that no one else has. So it could really be a life-changing gift to be able to pass those lessons on, a decade from now or 5 decades from now. So With that, I'll wrap up. If there's anything I can answer, please let me know. Anything we can do to support your work. And just thanks for your time here today. And I'll turn it back to Summer, I think.
Awesome. Thank you so much, Lauren, for starting us off talking about the state level of emergency declarations. All right, I'm going to try to share my screen now. Awesome. Can y'all see me? All right, fantastic. Okay, great. Awesome. So once again, thank you so much, Lauren, for talking about the state level of emergency declarations, what was going on at the state level. And so now I'm going to talk about the federal level. So we're going to walk through the different federal emergency declarations, talk about the distinct different types of emergency declarations and the powers that were enabled by each of these. And then we're going to talk about what's changing after the public health emergency ends next week on May 11th. Isn't that crazy that this time next week we'll be hours away from the PHE ending after 3 years? So as Lauren has briefed us, we had multiple levels of emergency declarations happening over the past 3 years. Internationally, we had the World Health Organization declaring an emergency of international concern at the end of January, and multiple foreign governments as well declared emergencies. In the federal level, we had emergencies declared by former President Trump and emergencies declared by HHS leadership. And then, as we saw, every single state, multiple tribes, and many locales also declared emergencies. So Lauren showed us this slide a few minutes ago, but going back in time to the earliest days of the pandemic, our first emergencies were declared at the end of January by HHS, by former Secretary Azar. The public health emergency, which is the one that is ending next week on May 11th, infamously next Thursday. A few days later, we had another PrEP declaration. And then on March 13th, former President Trump declared dual national emergency declarations. And then a week later in March, the Defense Production Act. So these are all a lot of different distinct powers and very confusing. What does each one do? What's ending? What's not ending? So we're going to break that down further and discuss that. So our first emergency was our PHE, the public health emergency, declared at the end of January by former Secretary Azar. And this is the legal authority of the public health emergency is the Public Health Service Act. And this has to be renewed every 90 days. And it has been renewed every 90 days for the past 3 years, for a grand total next week of 1,196 days, which is, of course, no surprise, the longest PHE we've ever had. Before COVID, these are mostly declared due to national disasters like hurricanes, wildfires, and usually just very local. Just very targeted areas. But here, this has been nationwide. So this has been the most massive use of these authorities ever, completely unprecedented. And what the PHEs does is that it permits federal law waivers. So like CMS waivers, we're going to talk about those in a few slides. It also facilitates interjurisdictional coordination. So this is really important when you have multiple declarations among states and tribes and locales, and the federal government really helps coordinate between all these different players in real time. And then finally, the PHE supports medical countermeasures, so like our COVID vaccines that we all got for free for the past 3 years, and then social distancing measures as well, as we all are intimately familiar. So after 3 years, almost 3 years to the day after President Trump first declared the emergency, the White House announced that the PHE would be ending on May 11th. And then a week later, HHS Secretary Becerra sent a letter to governors to prepare them for the final renewal, just confirming this would happen. And this is important because we don't want to just end the emergency immediately. We want to give states and healthcare systems and facilities and workers time to prepare for the end of the emergency because a lot will be changing legally. Our next emergency is our PrEP Act, and that is also under the Public Health Service Act. And the PrEP Act is our liability shield. And this is important because we know from documented empirical studies that healthcare workers will not show up to respond to emergencies unless they are assured that they will have liability protections. So the PrEP Act provides layers of liability shields for healthcare workers. It also expands who can provide certain services. So we saw pharmacists and dentists and even pharmacy techs being able to provide COVID shots during the emergency. And just expanding the scope of practice for a lot of different providers. But this is separate than our public health emergency. And a few weeks ago, Secretary Becerra sent another letter to governors confirming that the PrEP Act will extend past May 11th. So while the PHE is ending, the PrEP Act will not be ending yet. So all of our liability protections will continue. Next, the FDA emergency use authorizations, or EUAs. These are great because they've allowed the FDA to get COVID vaccines developed very quickly and get them on the ground and approved. So they're still tested, they're still safe, but they don't have to jump through all the hoops and go through all the bureaucratic red tape, we say, that they would normally have to do. And this does require an emergency declaration before this can be put into place. And so that was the PHE declaration that happened a few weeks earlier, back in 2020. But this is legally distinct from the PHE, even though it requires the PHE to put this into place. And a few weeks ago, HHS or FDA confirmed that this will be continuing past May 11th. So they set out this, I have a link here that you'll get it later after the show, but FDA has issued some guidance that they have 3 phases where they're going to be slowly phasing out the EUAs that are in place. So phase 1 is going to start on May 11th as the PHE ends, and it's just giving everyone time to prepare for phase 3. And then phase 2, 90 days later, that's going to allow device makers to issue corrections and removals, or they can, if they want to keep their product on the ground, they have requirements that they need to fulfill. And then phase 3 is going to be 180 days later, where the EUA is finally going to phase out. Next is our Stafford Act and National Emergencies Act that President Trump declared simultaneously in mid-March. And these enable a lot of similar powers as the PHE, but this is declared by the president, not by HHS. And these are not renewed every 90 days, but they can be terminated by a joint resolution of Congress or a non-renewal. And the national emergency authorizes FEMA disaster relief funds and access to that. It allows states to seek federal reimbursement for their response efforts, and it prevents other federal law waivers and flexibilities. So we'll talk about those in a little bit. That'd be like Medicare, Medicaid, CHIP, and HIPAA waivers and flexibilities. And this one is not renewed every 90 days, but remember that a joint resolution of Congress can end it. Well, that's what our Congress did. First, the House just passed a bill to end the national emergency, then the Senate passed it, and they sent it to Biden to sign. So he did sign that, and the national emergency ended a few weeks ago in April. But the PHE is still continuing on. So at this time, there's a lot of confusion of what's ending, what's not ending. And this mainly affected states' Medicaid programs where they could keep in place all of their current flexibilities and waivers they had going on, but they couldn't get any new ones. But as we'll talk about a lot, is the biggest powers that we think of are all tied to the PHE, and those continued on. And then our last emergency that we'll talk about is the Defense Production Act, which again is legally distinct. So this is at the end of March, President Trump first used this, but the Defense Production Act is a Cold War era law that allows the federal government to compel U.S. manufacturers to produce scarce resources. So at the time, it was ventilators, masks, PPE, where the president was compelling private companies to drop everything and produce whatever we needed. This has been in place the whole time, and President Biden has used it to compel production of baby formula and other scarce resources. But again, this is legally distinct from the PHE, so this is still ongoing. And if he needed to, President Biden could invoke the DPA to compel production of anything else we would need. Okay, so that's all of our emergencies. There's a lot of powers, a lot of overlap there, but what is changing next week and what's not changing next week? So let's break that down a little bit. And there's just, like I said earlier, there's been a lot in the news and a lot of confusion about what's tied to the national emergency, what's tied to the PHE, but that's why we're here to break it down. So first, with COVID vaccines, we've all been enjoying getting free vaccines from the government for the past 3 years, and boosters, and rolling out every few months. So what's changing here? Well, starting with what's not changing is that all of the vaccines that the federal government has already purchased and that are still on the ground, all of that's not, all that is still available. So as long as people want to access those vaccines, that supply is still going to be available. But of course, the uninsured may have access, may have issues getting access to vaccines after that supply dries up. And health plans, they no longer have to reimburse. During the PHE, health plans had to reimburse out-of-network coverage for vaccines. So if you went to an out-of-network provider, your plan would have to reimburse them, but they no longer have to do that at the same rate. But what's not changing is that since CDC has added the COVID vaccine and boosters to its list of recommended services, recommended preventive services. Under the ACA compliant plans have to cover the COVID vaccine at no cost. So those with private insurance coverage are still able to get their COVID vaccines. But one thing that is changing is that Medicaid and CHIP, their funding to provide COVID vaccines, excuse me. Can you all hear me? I'm so sorry to break up there.
I can hear you.
Okay. Okay, sorry guys. Technical issues here. Okay, great. Well, picking up with that, talking about vaccines. So Medicaid and CHIP coverage, that was tied to the PHE, but the federal omnibus spending bill at the end of last year did sever that. So that was completely severed now. And then talking about vaccine mandates, all of that is not tied to the PHE legally. So any vaccine mandate is legally distinct, so those would still be in place. And then what about COVID tests? So just like our COVID vaccines, those tests may not be covered by insurance anymore. And then if you're going to, any out-of-network coverage would not be in place either. But health plans can still cover COVID tests if they want to. So that would still be the same. What about telehealth? So telehealth was greatly expanded under the PHE, and it's been very, very popular. We've seen a lot of growth with Medicare beneficiaries in particular. But that federal omnibus spending bill back in December did sever all the telehealth flexibilities from the PHE, so it's no longer tied to that. And it's going to continue on for another 151 days. And so Medicare beneficiaries, health centers, rural health clinics, all these different populations that had expanded access to telehealth during the pandemic are going to continue to see that for another 151 days. In HIPAA, one thing that the PHE did was it relaxed a lot of HIPAA requirements. Providers are able to use like non-compliant use services that would not normally be compliant, such as Zoom or Skype to talk to patients, and they wouldn't have to worry about some being cited for HIPAA violations. So that has all been relaxed. But all of these waivers here and relaxations will end on May 11th with the end of the PHE. So providers will have to comply with the pre-PHE HIPAA requirements. Some states did have their own means to relax HIPAA and privacy requirements, or not HIPAA, but like their own privacy requirements. But many, as Lauren just told us, most states all states are ending their PHEs or their own emergency declarations next week as well. So they would probably lose a lot of that when they end their emergencies. And with talking about Medicare and Medicaid next, Medicare Advantage plans were required to cover services at out-of-network facilities, but all of that, they will no longer have to be required to do that. Hospitals were receiving a increased funding when they had a COVID-19 diagnosis on their Medicare claims, but that will be going away next week as well. And then Medicare Part D was also requiring, they were also covering 90-day supplies of certain drugs, and they will no longer be doing that at the end of the PHE. And then with Medicaid, states will be losing a lot of their flexibilities with the PHE, but the continuous enrollment where just people that were on Medicaid were able to stay on Medicaid and just can be continuously re-enrolled. That was untied from the PHE with the federal bill back in December. So that did end about a month ago on April 1st. So this has been pretty disastrous, as you all know, where we saw the greatest increase in covered Americans on insurance during the PHE, the all-time record highs, and seeing a lot of states just losing that where they're not keeping their expanded Medicaid eligibility options has been really disastrous. Although some states have voted in the last midterm election to expand their Medicaid programs, that's been one positive out of all this. And then finally, before I turn over to Professor Gostin, private health insurance, as we've already said, out-of-network services such as vaccines and treatment, those may no longer be covered. One thing that's interesting is mental health parity may be affected. That's where plans that cover physical services, they have to cover mental health services as well at that same or at a similar rate. So that may be effective if plans are no longer going to cover preventive services. But plans are still able to cover testing and treatment if they want to. All right, well, thank you so much for that, letting me share that brief introduction to what's changing, what's not changing. And now I'm delighted to turn it over to Professor Gostin. So thanks so much.
Thanks very much, Lauren. Thanks very much, Erica. Both of you were really just so thorough, so learned, and that there's, I don't think it's going to be helpful for me to really try to elaborate on, what's ending and what's not ending. I think what I'll do is just reflect just a few minutes on where we are in the pandemic, whether or not this is the right moment to end it, and why not, and also maybe talk a little bit about data collection and things like that I think are quite important. So I think the very first controversy around all of this is the question of, should we be ending the emergency now? Many people worry about that, and they worry about it for two reasons. The first reason they worry is because we have continuing unacceptably high levels of hospitalizations and deaths. So we have over 1,000 deaths a week reported by the CDC. So while on May 11th, the public health emergency may be going away, that doesn't mean the suffering is going away. We're going to continue to see a steady drumbeat of hospitalizations and deaths, particularly among the elderly. We're likely to see a continuing pattern for the foreseeable future of COVID surges and wanes. This fall, it's possible we might find ourselves in the midst of a trilogy of infectious diseases. COVID-19 could be surging, influenza, and RSV, which would strain the health system, and the surge capacity that the pandemic has allowed hospitals wouldn't be there to pick up that kind of slack, which is a big problem. So the first reason people worry is because they think that this means kind of we've left the health crisis behind when we haven't, and what this is going to mean for the most vulnerable. The second reason that people worry is because of the very specific things that Erica just talked about that are going away. And some of the it's a real jumble, as you could tell from Erica, about which public health emergency act or a health emergency act or a national emergency act or PrEP Act or whatever it might be. People don't make these distinctions between all of these various different acts. And then some things will be going away when the public health emergency ends. Some things have been decoupled from the emergency by Congress itself. Some have been cushioned because the administration has pre-purchased a lot of vaccines and other medical goods. So all of these things make people worried. And they worry because we have already a very weak health and social safety net in the United States. And COVID enabled us to upgrade, to create a health and social safety net that was much more robust, not just with respect to this pandemic, but with respect to all health and social care that we've come to expect. And so the concern is that we're going to see a continuing withering away and chipping away at the health and social safety net by the end of this emergency, by wind downs that Congress has already preset, by states that may be lowering benefits from Medicaid and other services. And this is a problem that's unique to the United States because we started with such a low line on our safety net in terms of, housing and healthcare and access to health services and the like. And so these are the two reasons why people are very concerned about the emergency going away. One, that we're continuing to see a lot of cases, deaths, and hospitalizations. And secondly, because of this rightful concern that America is not a very safe and healthy place to live and to bring up your children if you need health and social services. But having said that, I do think the emergency should end. All emergencies must come to an end. And right now we're well into the 4th year of the pandemic. And I think if you have emergencies that just linger and linger and linger, and when the public has long ago moved on, it erodes public trust in public health authorities and in government. And the next time that we wanted to declare an emergency, it will be much more difficult to do that. Tomorrow, the World Health Organization Emergency Committee is meeting. In fact, 2 emergency committees are meeting. One, they're both in Geneva. One is going to be on reviewing whether or not we should continue the public health emergency of international concern for COVID-19. And the other one about whether we should continue the emergency for monkeypox. I expect the emergency committee in both cases to recommend ending of those emergencies, although it's not sure for the same reasons I've talked about. And I expect Tedros to accept those recommendations. And so even before May 11th, as early as this week, we're likely to see the end of the COVID emergency and the Mpox emergency at WHO. The difference, of course, is when you end the public health emergency of international concern, you really don't unravel any WHO powers, whereas here you're unraveling a lot of HHS and other powers that and protections of ordinary citizens that really need protection. And so the answer really is to beef up our social and healthcare safety net so that we're ready for the next pandemic. And when the next health crisis hits, we want to be able to have that kind of surge capacity that we don't have, particularly in our hospital system. And I mentioned earlier, I'm a little bit concerned that our hospitals may not be prepared for the next surge. There is an area that we haven't talked a lot about, but I think it had been mentioned, is CDC's data authorities. If you look back on the pandemic, clearly CDC and FDA have gotten a lot of flack. Most of it's been unwarranted because the agencies were using gold standard scientific evidence, but that evidence evolved at the time. We didn't have a lot of understanding. People forget how scared we were and that we wanted to, and we looked to our health agencies to protect us. And so the precautionary principle, when science was uncertain, to act to save lives seemed sensible. But sometimes CDC and FDA did things in mysterious ways. why it took so long to recognize aerosolized spread, the controversy which lingers to this day over the efficacy of masks and what kind of masks, in the recent Cochrane studies suggesting that population level mask use was ineffective. Now, of course, I think just yesterday, FDA and CDC said that to have one mRNA dose means you're fully vaccinated. It doesn't seem to be supported by any science whatsoever. And so sometimes CDC and FDA shot themselves in the foot. Sometimes they, most of the time, they acted with great resilience. But if you look back, one of the things that was really interesting is that if we wanted to know the answer to an important question, does this vaccine work? In what age groups? What's the durability of the vaccine? What is the impact of the new Delta variant, the Omicron variant, whatever it might be? What is the effectiveness of various treatments like monoclonal antibodies or Paxlovid? We often looked to other countries for the answers to those questions, whether it was the UK, Israel, South Africa, the European Union. And the reason is that CDC has been hampered in its data collection. We don't have a national health system like other places do. And we also don't have a universal surveillance system because states gather the information in various different forms, various different kinds of information. Some share it with the CDC, some don't. Some share some things and don't others. Others use sophisticated data systems. Others just kind of fax their reports over to CDC. And so it's a hodgepodge. So CDC created data use agreements during COVID-19, and now it's scrambling to kind of renegotiate data use agreements, not just within the 50 states, but in cities, territories, tribal authorities, hundreds of different data use agreements, and that's no way to do surveillance and public health research. So all in all, my view is that it's right that we end this emergency because all emergencies must come to an end to regain public trust. Secondly, that we need to beef up our health care and social safety net so that we don't rely on surge capacities for what should be ordinary, everyday safety nets for our most vulnerable residents in the United States, and equal in all states in terms of the kind of robustness of the protection, their health, and then to ensure that we really upgrade to a modern 21st century data system for CDC. So with that, I'll end thanking you, Erica, and I'll turn it back to you, or Summer.
Thank you to our amazing panelists for giving us such great information today. Now we'll begin our Q&A session, and I'll go with the first question, which is to Erica. Does the network have a chart of regulations and waivers changing now that the PHE is ending?
Yeah, thanks for the question. Well, all these slides that we presented will be available on our website after the show, and Western Region is working on a cheat sheet of everything that's changing. We've been following this since day one, so hopefully soon that will be available on the network website.
My second question is also for you, Erica. Which telehealth flexibilities were extended by the Consolidated Appropriations Act of 2023, and will providers still be able to prescribe controlled substances via telehealth?
Yeah, there is a list, I think, on HHS's website of what exactly was extended, what's been made permanent. But most of those generally are location related, where which facilities can serve as a home for the telehealth services. And then like Medicare beneficiaries' abilities to receive telehealth services for an extended list of services. So before the PHE, it was just like a very small list of services they could receive telehealth services for. That's been extended. So for example, like mental health care, I believe has been extended. And you asked about controlled substances.
Yes.
Okay, that was one of the ones that is not permanent. So that was a PHE era extension. So being able to prescribe controlled substances via telehealth, I believe that'd be ending with the PHE.
Awesome. My next question is for Professor Gostin. Do you think that there has been permanent damage to the credibility of public health agencies and officials at federal and state levels? And if so, what can be done about that?
I think any impartial observer would say that there's been a huge trust deficit between public health and the public. There's no question about it. You can see it in the way that people like Tony Fauci, who was once venerated, is being castigated now. And you can also see it in the lack of trust, mostly in the CDC, but also at state and local levels. I'm sure Lauren could talk about that and will. And this is a huge problem because public health really needs the trust of the public. Without it, they can't get compliance with their recommendations when they ask the public to do certain things, whether it's mask or get a vaccine or to stay at home. It's much less effective. So how do we build back trust? Part of it is trying to correct and the damaging messages that are given on social media, where there's a lot of disinformation and misinformation. Part of it is that senior politicians themselves are denigrating public health agencies. In fact, all government, all agencies, and that's a very toxic environment. And part of it is that FDA, CDC, HHS, and others really need to do a far better job of health communication. If you want to be trusted, you need to be trustworthy. And so I think we need to have trained health communicators at public health agencies at the local, state, and tribal and federal levels. A good public health communicator should always say this honestly and clearly and simply: this is what we know, this is what we don't know, and this is what we're doing to try to find out what we don't know, so that there isn't the expectation that advice given now will continue on. And also just to make decisions based upon science and evidence and not try to guess, politically what the right thing to do is, and be clear and simple. So those are a few things that we need to do, but it absolutely is a significant and serious problem that we need to work on.
My next question is for you, Lauren. Can you speak to how some state orders evolved throughout the duration of the pandemic?
Yes, and I'll try to be brief because I know there's a lot of other questions too, but it was really fascinating to watch, as we talked about the different mechanisms and different statutes that states have to rely on, it varies by state. But if an order was struck down by a court, we had to see how states, maybe went from a gubernatorial order to one from their state health official, shift in that way, or evolve from general emergencies to limited emergencies, or even as the pandemic went on, zero in on specific issues like supply chain disruptions or disaster orders to recovery orders or nursing staff shortages. So just kind of seeing states know what kind of tools are at their disposal and how to kind of navigate that and apply it to the specific situation as the pandemic evolved was really interesting to see, just that adaptation.
And Erica, my next question is for you. How will the EUAs on treatments such as Paxlovid, Molnupiravir, and Veklury be affected? And will the government no longer distribute them?
Yeah, so per the guidance that FDA released about EUAs, there's going to be that 3-phase kind of wind down for those. So manufacturers can choose whether or not they want to try to get their product fully approved and out there permanently. So they'd have to follow that guidance from the agency on how to do that. So it's going to depend on what the manufacturers decide to do over the next several months. That would depend on them. But yeah, I'd look at the FDA guidance that was linked in the slide.
And Professor Gostin, what legal mechanism would you recommend to upgrade CDC's disease surveillance systems and authority?
There are constitutional problems here because the federal government can't direct states to do anything. So I think that the authority will have to come from Congress along the lines of say, conditional funding, that is a condition of receiving certain federal public health grants, that states have to share information with the CDC, and to do so in a certain form, so that we can really upgrade our systematic collection of information in a form that can be the most effective. CDC's also gotten a lot of congressional funding to upgrade their antiquated data systems. But as Rochelle Walensky points out, I think quite correctly, that's not even as much as, say, a large teaching hospital will spend on their data information systems. And so we need to upgrade their data information capabilities. We also need to upgrade the data information capabilities of states, localities, and territories. It's very, very important because they're highly variable. And then we need to have clear incentives for sharing, national sharing of information.
So about 3 more minutes, so I think we'll have time for 1 or 2 more questions. My next one, I think, could be to Erica or Lauren, or if both want to weigh in. Which professions authorized by the PrEP Act declarations, notwithstanding state law limitations, will continue past May 11th? And if so, is there an end date for the preemption?
Yeah, I can jump in first, and Lauren, if you want to comment on this too. So HHS did confirm a couple weeks ago that the PrEP Act declaration is going to extend through 2024, the end of 2024, and those liability protections are going to apply to pharmacists and pharmacy interns and techs, and they can they're going to be able to administer the COVID vaccine. So I can pop those guidelines in the chat as well. Lauren, did you want to weigh in on that one?
I won't weigh in case we want to get to one more question.
Okay, so our last question is for Professor Gostin. What ideas do you have for public health to advocate for the expansion of surge capacity in the light of closure in the last 2 years of many smaller hospitals due to financial insolvency?
Well, I think overall that what the pandemic has taught us, we haven't taken to heart. And so I would really like to see a 9/11 type commission that was authorized by Congress, that was nonpartisan, that would learn the lessons of COVID-19, and then to ensure that the failure to have that kind of surge capacity in our hospital systems, particularly in rural areas and other areas of America, poorer areas of America, it's really not acceptable. And we're at a turning point here in America as the pandemic is kind of officially ending after 3 years. We can either go back to complacency, and there are a lot of signs we're doing that, or we can make a really strong and determined effort to learn at the highest levels what those lessons were, to apply those lessons and to get the kinds of resources, flexibilities, powers, health and social safety net from the Congress that we so desperately need. Needless to say, I'm not that optimistic with this Congress, but I know as a matter of moral certainty that this is something that we need to do to protect the American population.
And we're just out of time. So thank you everyone for joining this fascinating discussion. And please feel free to reach out to any of our speakers for any further questions that we didn't get to.
Yeah, thank you all so much. And thank you so much to Lauren and Professor Gostin for joining us today as our special guests. This was really wonderful. So thank you all so much. Hope you have a great rest of your day.
Thank you.
Yeah.
And happy last week of the PHE.
I do have a couple quick notes for attendees before you all head out. I'm also going to say a quick thank you for everyone's participation in today's webinar. As a couple of final notes, we just want to welcome everyone to our Public Health Conference here in Minneapolis, Minnesota this October. Registration is open and available, as well as some previews to some sessions that will be throughout the 3 days. But also, you will be getting an email from ASLME post-webinar to go about CLE credits if that is something you're looking for. But other than that, that concludes today's webinar. So thank you for attending. Have a great rest of your day.